Well, thank you, Sonia. So next we're going to hear from Mike Stoner, who's going to talk about TCAR. What do the VQI results say? Is there a threat to the numbers?
All right, so I'm not sure what the threat is, but I'm going to talk a little bit and talk to Vinky about this a little bit in terms of trying to dovetail into the other talks as well. So I will touch on the VQI data and summarize it, but I'm going to talk a little bit about the NCD changes as well and the pros and cons of that moving out. So carotid endarterectomy has been around for 70 years, and it's tried and true, and it's a fantastic procedure. It is the undoubted gold standard in carotid therapy. 10-year analysis from ACST shows that the deferred CEA group, patients undergoing provisional revascularization, not randomized revascularization, have a higher stroke rate. So it's pretty convincing, both symptomatic and asymptomatic, and Dr. Noor touched on this to some extent too, the benefit of guidelines-based carotid revascularization. It scales down to very small hospitals. It scales to surgeons of pretty low volumes, even lower than the SVS guidelines. These are New York State data that we looked at of stroke death rate. These lines and graphs are difficult to interpret. If you look at, though, the bottom line, if a surgeon does more than 5 CEAs a year and a hospital does more than 11, they provide outcomes as good or better than the SVS recommended guidelines. So essentially, CEA is an optimized procedure. So it's the most studied, most mature vascular procedure that we really have in vascular surgery right now. DAP, statin, neuromonitoring have all become standard of care. Protamine are the norm. It scales to small hospitals and provide excellent outcomes. There's efficacy in asymptomatic patients, and the timing of it after stroke event is pretty well established. So all seems settled, and then the minimal access procedures come along. And so the minimal access procedures originally proposed in high-risk patients, and these are some of the data in the JVS from the Cleveland group that demonstrated the demographic and anatomical considerations for creating this high-risk cohort of patients. Became the basis of many of the carotid stent trials, including the Sapphire trial. But what we really realized with CREST data was the higher procedural stroke rate seen with CAS, so sort of a Rubicon where the endovascular revascularization revolution, from a vascular surgeon's perspective at least, sort of stalled at the carotid bifurcation because of the atheromatous arch and all the different embolic potentials of moving devices and hardware up there, and the stroke rates of CREST-1 are shown therein. So the theory of TCAR is the proximal protection placed in a simple surgical incision at the base of the neck obviously provides benefit, and I'll go through these very quickly because Dr. Lumsden touched on this and Dr. Zhao as well about MRI. But basically you see with TCAR, TCD hits at different timing of the procedure, but total TCD hits and MRI hits in line with the surgical revascularization of CEA. So what do the VQI data show if you begin to look at stent procedures in transfemoral stenting versus TCAR? And this is a paper that was published in JAMA from the Johns Hopkins group, and the Kaplan-Meier curve estimated stroke death of patients undergoing TCAR versus transfemoral carotid artery stenting. You can see a differential that's statistically significant in stroke death rate. Now, the VQI data set evolves over time and grows, and so there are a myriad of VQI papers to look at, but just to highlight 3 or 4 of them about what the bottom line is from VQI is that the procedural adverse event rate when in both raw adverse event rate and when matched and propensity matched for anatomical considerations and for patient factors shows a higher adverse event rate with TCAR compared to transfemoral carotid artery stenting. And this is a summary graphical abstract from one of the many San Diego abstracts that has looked at this. If you start to look out further, though, in the propensity-matched analyses in VQI that look at stroke rates over time, over the first year after carotid revascularization, comparing transfemoral stenting, CEA, and TCAR, what you'll see is there's not really a statistical difference. So the risk is bundled up into the peri-procedural risk. The curves have some divergence there, but these data sets are very, very large, so it's difficult to make the proposition that if you just add more tens of thousands of patients, you'll make statistical significance because there already are tens of thousands of patients in there. So the summary of it from a VQI perspective is that VQI, one thing I'm a big fan of the use of VQI to monitor new technology, and this may be one of the ideal applications of VQI. I will caution, though, the VQI data is the selection bias therein, and VQI is originally designed as a quality improvement database, much like NSQIP. It's not designed to address surgical decision making. So you can propensity match, you can match anatomies, et cetera, but you don't really know unless you get down into some very sophisticated center-based statistics to try to remove biases, how well you can correct for the selection bias of the different cases. And RCT data are unavailable. So what about transfemoral carotid stenting? Well, it's not quite dead yet, right? So it looked like from the data I present and most vascular surgeons, the enthusiasm that many vascular surgeons have shown around TCAR is that, well then, TCAR is our new minimally invasive thing and we just shouldn't do transfemoral stenting because of that delta early in the procedure. This slide has been presented, I think, twice before, so I will skip over it pretty quickly, but this is part of the Multi-Specialty Carotid Alliance documentation that was sent to CMS that became the basis for then the public forum and the changes around the NCD 20.7, but the bottom line is if you look at CAS procedures over time, the risk of the procedure or the safety profile has improved. So transfemoral carotid artery is becoming, CAS is becoming safer over time if you look at the literature. Largely, we've removed now with the coverage decisions many of the restrictions around transfemoral carotid artery stenting. There are some caveats about the shared decision-making tool, which is not really well defined. And the real questions we start to have is, do the outcomes scale of these trials? Do they scale to the real world? And the technical space, until of late, has been relatively stagnant because of the lack of commercial uptake in the United States. There are some technical innovations, which I think we'll touch on in this forum. So does transfemoral carotid artery stenting scale? Well, this is outside the confines of my talk to restrict it only to VQI. This is a Phil Goodney paper that does look at CMS beneficiaries, so using CMS data. And if you look at patients undergoing transfemoral carotid artery stenting, you'll see, though, that the operator volume shown on the histogram on the left is clustered in a very low operator volume, right? And this is prior to the NCD 20.7 changes, so maybe this will change. But what you will see is that mortality scales with volume. So as volume goes up, mortality goes down. And use of an embolic protection device improves with volume as well. So lower volume operators have higher death rates and are more likely to fail to use an embolic protection device. So it does call into question, do things scale? So a couple more slides. What are the pros and cons of the changes that have now been enacted by CMS? Well, the benefits are that patients benefit from a full therapeutic spectrum now. Access to best medical therapy, CEA, TCAR, transfemoral stenting. Access to these anatomical treatment modalities can now be extended to vascular deserts, areas of the country that do not have a vascular surgeon or any other provider or a readily available referral network to get patients to someone who can provide CEA. We've had 20 years of operator and environmental medical improvements, and it removes cranial nerve injury risk, which is something that we as surgeons don't really talk much about. It is part of randomized trials, but a real-life ENT or neurological examination for cranial nerve injury will show a much higher volume than you would think. So what are the drawbacks of the expansion? Well, there's a lateral diffusion of technology that may dilute expertise. If it becomes a bit of a Wild West, you'll have more of those low-volume operators that have higher mortalities, that have less likely to use embolic protection devices correctly, et cetera. There's a non-surgeon bias against CEA and TCAR, so how well will the shared decision-making tool come out? And I'm not proposing that you just have carotid revascularization only done by people who do best medical therapy, CEA, transfemoral, and transcarotid artery stenting, because you'd restrict it to such a small overall group of operators then that you would end up restricting access to carotid care. Stenting is more expensive. Both transfemoral carotid artery stenting and TCAR is more expensive because of the hardware. I think that this will be offset. If all the complication rates approach each other, but that is yet to be completely seen. It may lead to a lack of inappropriate procedures, a lateral diffusion of technology, and there's a lot of pros and cons about sort of this democratization of technology, moving things to OBLs, moving things to outpatient and ambulatory surgery centers inside or outside of hospitals, but by basically increasing the denominator of people that can do it, lowering the activation energy, it may lead to inappropriate procedures in places with tight supply-side type economic markets. VQI does suggest that transfemoral carotid artery may not be as safe in the immediate peri-procedural period. Certainly the long-term safety and efficacy about the same. Finalize the loose ends, and I think Frank's not here. Frank Arco was supposed to speak about carotid calcium, so I did leave this one slide in, that calcium is bad for transfemoral carotid artery stenting and TCAR. So we did a volumetric analysis study that we presented in the Eastern last year that demonstrated that if you use TerraRecon and calculate the volume of calcium within the carotid plaque, as soon as that volume gets above 18%, so a good number to remember is 20%, that TCAR doesn't work very well. It has a higher incidence of in-stent restenosis over time, a higher hemodynamic failure rate at the first post-op ultrasound as well, and the same data would be extrapolated to transfemoral carotid artery stenting. Calcium also correlates with long-term survival after carotid revascularization. So actually just calcified vessel are a marker of death, both in CEA and CAS. But it does lead you to a strong, just procedural bias towards CEA for very calcified plaques. There may be a role for intravascular lithotripsy. I will just say what I've been saying at meetings for the last year, and I think it's a great idea, IVL in this space. It is contraindicated in the cerebral vascular space, so I actually think that it should not be used outside of an IDE or a clinical trial. So in closing, CEA is an absolute gold standard. This is still demonstrated in VQI, and all the VQI projects do use that as a control group, which is obviously correct. TCAR results approximate CEA, but you can't bend the rules. You can't do bad access. You can't do calcium without expecting outcomes that will, over time, bend the outcomes. Transfemoral carotid artery stenting adoption ramifications are yet to be really seen. And the real question is, will the decreasing stroke rate demonstrated in Dr. White's paper in the Multi-Specialty Carotid Alliance, will it pan out when this is scaled to the real world, and how are we going to figure this out? Thank you.